Morning. Can you come forward? Who are presenting the case?
Yes, sir.
Starting with history.
Yes, sir. Good morning, sir. Good morning, everyone. My name is Kaya Bigna. I'm going to present a case. A 32-year-old female patient who is resident of Paderu and laborer by occupation came with a chief complaint of shortness of breath since 2 months and palpitation since 1 week. History of presenting complaint. Patient was apparently asymptomatic prior to the onset of illness. Patient complains of shortness of breath on exertion, which is insidious in onset and progressive. Shortness of breath is aggravating on exertion and relieves by rest. Patient also complains of palpitation since 1 week, which are insidious in onset and relieves on taking rest. Patient also complains of easy fatigability and edema. She has no history of orthopnea
Hold
and
on 1 second. Whenever you were saying about shortness of breath, when you start with a smaller grade and you are ending up with a large class, then you should go for explain. In the beginning, he used to have even with a severe exertion, and slowly it graduated with minimal exertion, and now with a daily activity. Okay,
okay. Okay.
continue.
She has no history of orthopnea and paroxysmal nocturnal dyspnea, no history of chest pain, cough, syncope, no history of fever and hemoptysis, no history of bronchial asthma and COPD. Past medical history. Patient has episodes of rheumatic fever in her childhood, which was treated symptomatically. No history of bronchial asthma, COPD, no history of congenital heart diseases, no history of hypertension, diabetes, and TB, tuberculosis. Past surgical history, no history of any previous surgeries, no history of blood transfusion. Drug history, no significant drug history. Family history, no history of similar complaints in her family, no history of sudden cardiac deaths in her family, no history of diabetes and hypertension runs in her family. Personal history, she takes mixed diet, normal appetite, sleep is normal, normal bowel and bladder habits, no history of alcohol and smoking. Thank you.
Once go to the first slide, second slide. Yeah, hold. Now you were saying about palpitations, right?
Yes, sir.
It is relieving with rest. What are you expecting by adding relieving with rest? What it could
Uh,
be, the palpitations.
uh, uh,
And when you add in word this, and it started just 1 week back. Okay.
yes, sir.
And whenever you add since, you should say the date, right? Whenever you add weeks or days, you should go for from. Yeah. Or for 1 week, for last 1 week, right?
Yes, sir.
And for the 1 week, don't add this insidious. And generally, the palpitations will be intermittent. Okay.
Okay.
If you added relieves with rest, then it's most probably this is just a fast ventricular rate, which is causing palpitations.
Okay.
And the reason why I gave you palpitations is one of the most common causes of atrial fibrillation
Mm.
in developing countries is rheumatic heart disease.
Yes, sir.
And there will be intermittent atrial fibrillations. Okay, for that I gave palpitations. And in your case, as when you added relieving on taking rest, it could be just tachycardia, sinus tachycardia. Okay,
Okay.
and easy fatigability. Okay, among these, what is the most classic symptom in mitral regurgitation?
Shortness of breath, sir.
Palpitations is the most classic symptom, right?
Okay.
Not shortness of breath, and in fact, shortness of breath will be late onset when compared to palpitations.
Okay.
Remember the order. PAPA, D. Palpitations, fatigability, and dyspnea is the last one. Okay.
Okay.
In case of mitral stenosis, dyspnea, shortness of breath is the presenting component and most commonly the earliest one.
Okay.
In that case, dyspnea, hemoptysis, and syncope are the order of components. Okay. Next, we have mentioned about edema. So, what do you mean to convey with adding edema? And what do you mean to say by edema?
Um, right heart failure may lead to
You should elaborate what is this edema, facial edema, or lip edema, what edema it is,
pedal edema.
angioedema. You should write that and whether it is bilateral. And rather than edema, edema is usually a hmm, examination finding. You should say swelling. Okay.
Okay.
You should use the what the patient uses. Okay. Okay. Omit the edema whenever you are presenting next time.
Okay.
Am I audible?
Yes, sir.
Add swelling and you should add the grade of the in examination you should add the grade and in this you should add up to where the swelling is. Okay, up to ankle or up to knee. Hmm. Next, whether the edema is relieving with any postural change.
Yes. Mm.
Okay. Negative history, what you added was orthopnea and PMD.
TM. Chest pain, cough, fever.
What are you ruling out with chest pain?
Angina, sir.
Hmm.
Myocardial infarction.
Either MI or ischemic heart disease.
Ischemic heart. Yes, sir.
Okay. Next, with cough,
COPD and any infection, pneumonia.
does a heart failure patient don't present with a cough?
Yes, sir, sometimes.
What is the classic presentation of sputum in heart failure? Pink frothy sputum అని ఏమైనా అన్నారా?
Pink, M5. No, sir. No, sir.
Next, syncope. Okay. Syncope
Decreased
is a
left
classic finding
vascularity.
which valvular disease?
Mitral valvular disease, sir. Mitral regurgitation and mitral.
Give presenting symptom more in case of aortic valvular diseases. Okay, because it decreases the cardiac output.
Okay.
Hmm? Even in mitral it will be present, but it will be late. In cases of aortic, it will be early finding.
Okay.
Aortic stenosis per se present with syncope alone. Okay, go to the next slide. What is this? Was treated symptomatically? What does that mean?
And fever and the infection is treated.
Fever for which he was treated. You should add whether he had taken prophylaxis or not. Whether he is actively taken now or used it for some days or in stopped. The reason why I added this rheumatic fever is how you elaborate the history of rheumatic fever. Whether he is on prophylaxis or not, and how many days he got admitted. Okay, next one. Family history. What are the important things to ask in family history? What heart,
Hypertension.
what heart diseases can present with? Cardiomyopathies will present with. Will have a
History, family.
Coming to, okay, what did you ask for? No history of similar complaint in the family. Okay, no history of sudden cardiac deaths, either maybe due to cardiomyopathy
Myope-
or
Myocardial infarction.
channelopathies.
Oh,
So
okay.
channelopathies will cause ventricular tachycardia or ventricular fibrillation. Next, okay, coming to personal history. mm, how do alcohol affect the heart?
Dilated cardiomyopathy. Cardiomyopathy.
Mm, acquired cardiomyopathy.
Okay, cardiomyopathy.
Okay. What about this diet?
Uh,
Mm, just to rule out
um,
alcoholic
I
syndrome.
like. Oh,
Next is right diet habits for the lipid profile for the risk factors to rule out
yes, sir.
coronary artery disease. As the smoking and diet were mainly for ruling out coronary artery disease risk factors. Okay, go for
Oh,
next one.
okay. Just 1 minute.
Next presenter.
Good morning, sir.
One.
Good morning, everyone. Today I'm presenting the examination part of this case. On general examination, patient was conscious, coherent and cooperative, well oriented to time, place and surroundings. There were no signs of pallor, icterus, cyanosis, clubbing, lymphadenopathy. Bilateral pitting edema was excited. Coming to vitals, pulse is 105 beats per minute. It was regular rhythm, equally comparable on both sides with no radiofemoral delays. Blood pressure 110 by 70 millimeters of mercury in right arm supine position. Respiratory rate is 24 breaths per minute. Temperature is 98.4 degrees Fahrenheit. Coming to systemic examination, on inspection, precordium is normal. No precordial deformities were seen. Apical impulse is visible. On palpation, apex beat is felt in the left fifth intercostal area, just medial to midclavicular line. Systolic thrill in the apex. On auscultation, S1 was soft and S2 was audible. High-pitched, soft-blowing holosystolic apical murmur in the left lateral position. It was radiating to left axilla and inferior angle of scapula was felt. Ejection systolic murmur with loud P2 in pulmonary area was felt. Other system examinations, CNS, all sensory and motor reflexes are normal. Respiratory system, normal bilateral bronchovascular sounds are heard. GIT, no palpable mass per abdomen or any organomegalies like hepatomegaly and splenomegaly. Thank you.
Go for the first one. Here you mentioned about pitting edema. Mention up to where? Up to ankle or up to knee. Okay. It helps to know the chronicity of the disease. Okay.
Yes, sir.
As the disease progresses, heart failure progresses, it extends even up to the thigh. Okay.
Yes, sir.
Next. Hmm. You can add equally comparable or both sides, or you can simply write no radial delay. Okay.
Okay, sir.
And regarding you have mentioned 105, is it tachycardia?
Yes, sir. Tachycardia.
Why are you expecting tachycardia in this case?
It can be arrhythmia, sir. Respiratory sinus arrhythmia.
Respiratory, Respiratory sinus arrhythmia is a normal phenomenon or abnormal?
Normal, sir.
Normal. It's a normal phenomenon. It doesn't really cause tachycardia.
Okay, sir.
In this case, you have mentioned about pedal edema. What would be the cause of pedal edema?
Right heart failure can be.
Mm. Same, the same thing might be the cause of this tachycardia. Okay, heart failure.
Yes, sir.
Mm. And what do you expect? How do you explain the pulse rate in case of atrial fibrillation? The rate can be tachy or it can be normal. Okay, it is 105, just like here. And how will be the rhythm in case of atrial fibrillation?
Irregular rhythms.
Irregularly irregular. Okay, and among irregular, they are again classified into regularly irregular. Like if you miss every fourth beat or fifth beat, it is regularly irregular. If you're missing at an intermittent, regular pattern,
Yes, sir.
regularly irregular. Okay, when do you expect radiofemoral delays? Whatever you present in case, you should know why you added this. Okay,
Okay, sir.
coagulant will cause radiofemoral delay. Okay, and you added equally comparable on both sides. Hmm. What really matters for you to measure on both sides? In some patients, in one hand, the BP will be 90 by 60. Okay, it's almost a finding in a shock patient. That patient is absolutely fine and is doing well. And you got a doubt of whether there's some clink in the artery which is causing the low blood pressure. And you started looking
Sir.
to the other side of the other lip. And it was normal, or it would be high.
Yes, sir.
On the other hand, it was 120 by 80. And the other, in the first limb, it was just 90 by 60. Okay, there is something obstructing the flow in the first limb. Okay. Takayasu arteritis అని నేను విన్నావా? హలో.
Yes, sir. Takayasu arteritis.
Okay. Next, respiratory rate was 24.
24.
And here you should add whether it is abdominothoracic or thoracoabdominal. Okay. Hmm. Go for the next one. Wait, did you add JVP?
No, sir. JVP not added.
JVP?
No, sir. I didn't add JVP.
JVP is absent. You mean to say JVP is absent?
JVP normal.
Hello, Avinash.
Sir, JVP normal, sir. I didn't mention that.
You mentioned about pedal edema and you didn't mention about JVP, right? And JVP is the first thing to present in a heart failure and it's the last thing to vanish. Okay, you should mention JVP. Who asked you to remove yesterday? I think you added it. Go for the next.
Involve.
Okay. Hmm. Vertical impulse at where?
Fifth intercostal space.
In which position? In supine position or left recum? You should add that. Okay.
Okay, sir.
Next one.
Sir, palpation.
Apex beat is felt in the
Left to fifth intercostal area. Medial to the midclavicular nape.
in case of mitral regurgitation. Do you have any idea about the right heart apex and left heart apex? In case of mitral regurgitation, it is a left heart apex. Left heart failure will be there. The apex will be more lateral. Okay, it can not be a medial to the midclavicular. It should be either lateral. You should mention how many centimeters lateral to the midclavicular. Or
Okay,
if
sir.
to the anterior axillary line, you should mention at anterior axillary line.
Yes, sir.
And also you should add character of the apex, whether it is hyperdynamic apex or tapping apex or heaving apex. You should add that. Okay. In volume overload, this is a volume overload condition. Usually we will see a hyperdynamic apex. Okay.
Yes, sir.
In case of aortic stenosis, which apex you will see? Heaving apex you will see. Okay. Whenever there is a pressure overload. Okay, it is the stenosed valve against which left ventricle must contract. So against extreme pressures, it will show a heaving. Whenever the valve is overloaded, hyperdynamic.
Okay, sir.
Okay, go for the next. So next to on auscultation, whenever you say about yes, in cardial, in other systems, we can just mention S1 and S2. But when it comes to CVS, you should tell about at individual areas. Okay,
Okay, sir.
at mitral area or at apical area. Start with that, and then go with tricuspid area, and then pulmonary area, and then aortic. Okay, at mitral and aortic and mitral and tricuspid areas, we will comment about S1. Okay,
Okay, sir.
at pulmonary and aortic, comment about S1. And we
Yes,
should
sir.
usually use the word S2 in examination. Okay, in
Yes,
CV.
sir.
At pulmonary area, we will comment about P2. Okay. At aortic area, you will comment about A2. That's it.
Okay, sir.
I pitched soft, radiating to the left axilla. Okay. And inferior angle of the scapula was felt ఏంటి palpation కాదు was heard అని పెట్టింది. నెక్స్ట్ ఈ మర్మర్ గురించి ఇంకా ఎక్స్ట్రాగా యాడ్ చేయాల్సింది మ్యాక్సిమం ఇంటెన్సిటీ ఎప్పుడు ఉంది, ఇన్స్పిరేషన్ అప్పుడా ఎక్స్పిరేషన్ అప్పుడా? జనరల్గా లెఫ్ట్ సైడ్ ఇన్స్పిరేషన్ అప్పుడు ఎక్కువ ఉంటాయా, ఎక్స్పిరేషన్ అప్పుడు ఎక్కువ ఉంటాయా? Left heart sound increase with increase in expiration.
Okay,
Right.
sir.
Inspiration. It's so simple. During inspiration, negative pressure in the thorax
Lung volume increases.
will not only just air from the external environment, it also pulls the systemic venous pressure, systemic venous blood into it. Okay.
Yes, sir.
సో లంగ్స్లోకి రావాలంటే త్రూ రైట్ హార్టే రావాలి. So during inspiration, right heart sounds will increase. Okay. During expiration, lungs will push the oxygenated air. So up pushing అంతా through left ventricle అవుతుంది. So during expiration, the left heart sounds will increase. Two exceptions ఉంటాయి. మీకు ముందు బేసిక్స్ అయితే నెక్స్ట్ స్లైడ్.
Okay, sir.
ఓకే నెక్స్ట్ వన్.
Okay, sir. Finish.
Sir, is my screen visible, sir?
You go for the projection option. Okay, or play option.
Sir,
Go for
is
the
my screen visible, sir?
it's visible. This is a routine finding.
The
Okay.
most probable diagnosis for this,
What do you mean?
the most probable diagnosis for this case is mitral regurgitation.
You go for
Coming to the investigation,
you go start with provisional diagnosis before investigations. After investigations, we will go for a definite diagnosis. First, go for the provisional diagnosis.
okay. Differential diagnosis is tricuspid regurgitation
Before different,
increases with murmur increase.
hold on. Before provisional differential diagnosis, you should go for
Okay, sir.
provisional diagnosis. If you didn't add in the slide, you can just speak to me.
The provisional diagnosis is
Mm. Hello.
mitral regurgitation.
Mitral regurgitation. నెక్స్ట్ ఎప్పుడు
Now, coming to the investigations.
ఇటియాలజీ ప్రొవిజనల్ డయాగ్నోసిస్ అక్కడితో ఎండ్ అవ్వదు. ఇటియాలజీ చెప్పాలి. మైటల్
Okay,
రిగర్జిటేషన్
sir.
probably of
Probably of rheumatic fever in the childhood.
rheumatic etiology, rheumatic heart disease. Okay, probably
Rheumatic.
rheumatic heart disease.
Okay, sir.
Hmm.
In the childhood.
చైల్డ్హుడ్ అది రొమాటిక్ ఫీవర్ అది వాట్ మేడ్ యూ అన్నప్పుడు నువ్వు అవి చెప్పాలి. ఓకే, నువ్వు బయట ఎక్స్టర్నల్స్ ప్రెజెంట్
Okay, sir.
వాట్ మేడ్ యూ టు థింక్ అబౌట్ రొమాటిక్ హార్ట్ డిసీజ్ అంటే పాస్ట్ హిస్టరీలో దెర్ ఈస్ ఎ హిస్టరీ ఆఫ్ రొమాటిక్ ఫీవర్
Rheumatic fever.
and in a developing country, especially at the age of young age here at around 30, it's more chance of the prevalence is more.
Okay. A 32-year-old
Wait. I will.
A 32-year-old lady presented with shortness of breath on exertion and increasing in intensity for the last 2 months, with the onset of palpitations for the last 1 week, and on examination there is regular BP, normal BP, respiratory rate is 28 per minute, and the systolic thrill in the apex soft, S1 soft, P2 loud, and pansystolic murmur heard in the apical area with radiation to the left axilla And the provisional diagnosis is mitral regurgitation with rheumatic etiology.
What
Coming to the
you
investigations,
have heard is some summary of the, when I ask about summary, you should say, and in summary, you don't say the normal findings. Okay, whatever vitals you have said about, don't never
okay,
say
sir.
about the normal findings, only the important one. And the pedal edema is the important, and you should say about that. Okay. And 1 second,
Okay, sir.
provisional diagnosis not yet completed, and after MR with MR probably of rheumatic etiology, you should continue whether it is associated with congenital heart, congestive heart disease or heart failure or not. In this case, it's present with
Okay, sir.
congestive heart failure without,
Investi
without
heart failure.
atrial fibrillation is common. Here it is absent, so you should say without atrial fibrillation. Okay, this is the
Okay, sir.
diagnosis. Next, in,
Okay, sir.
in history, how do you grade the shortness of breath? Now we have come to the conclusion that it is
5 grades.
a heart failure case, and now you wanted to grade it. And how do you grade it?
Okay.
What is the name of the classification? NIHA classification, New York.
5 grades.
Okay, NIHA classification.
Okay, sir.
But when you started asking the complaint, you shouldn't immediately comment about NIHA classification. Okay, because you don't know whether it is due to heart failure or whether it is due to respiratory cause. The shortness of breath, the cause of the shortness of breath, we
Okay, sir.
really don't know. So we will explain in a descriptive manner. And when it comes to now,
Okay, sir.
when you come to the provisional diagnosis, now you can add. We already said about congestive heart failure. Now
Heart failure.
bracket or with you can add NIHA class, which class it is. If he is having even at rest, then it is okay, grade 4.
Grade 1.
I'm coming from the back. If it is even from the at rest, it is. And
Okay, sir.
NIHA we never use grades, we will use classes. It is class 4. Okay. With just daily activities,
Okay,
is
sir.
shortness of breath. We will go for grade 3, class 3.
Okay, sir.
Minimal exertion, okay, but like walking or washing clothes is getting shortened, then it is
Walking with friends or
okay. And class 1 is severe exertion, and there is other grading for the respiratory. What was that?
okay, sir.
MRC grading. Okay, medical research
Okay,
council
sir.
grading. And once go through MRC grading. Okay, now we continue with investigations.
Coming to the investigations, complete blood count, hemoglobin 8.9 gram percentage, total count 6,600 millimeters,
Hemoglobin
differential count 76 percentage, leukocyte 23 percentage.
wait, you mentioned about hemoglobin
Sir?
at 0.9 grams, right?
Yes. Yes, sir.
In examination, he said there is no pallor. You should have correlation. Okay, there must be
Okay,
coordination
sir.
among you. Okay, go. Don't read all this. Go for next slide.
Coming to the chest X-ray, PA view, there is cardiomegaly due to left atrial or ventricular enlargement. Enlarged left atrium suggests double density. This is due to left atria pushes the right atria. Kerley B line suggests pulmonary congestion. This is due to lymphatic engorgement causes thickening of the septa. Hence, horizontal thin lines are seen on the pleura, which are perpendicular to the pleura. In the lateral view, we can see walking man's sign. This is due to enlarged left atria, causes enlargement of the carinal angle. Coming to the ECG findings, there is left atrial delay, bifid P wave or notched P wave. Left atrium on encountering increased resistance will contribute to the enhancement of the P wave in lead 2 and lead 6. Second hump in the lead 2 becomes larger and negative deflection in the V1 becomes deeper. This abnormal P wave is also known as P mitral. In the ECG findings, we can also observe left ventricular hypertrophy. In that tall R wave in the lead V6 and a deep S wave in the lead V2, we can see. This coming to the contour of the normal P wave, first depolarization of the right atrium starts and the depolarization and continues as the depolarization of the left atrium. In the P mitral, due to the left atrial enlargement, it amplifies. There is a second hump in the lead 2 and negative deflection in the V1. This is coming to the echocardiography. The echocardiogram is commonly used to confirm the diagnosis of mitral regurgitation. We can also do color Doppler test also. Color Doppler flow on the transthoracic echocardiogram will reveal a jet of blood flowing from left ventricle into the left atrium during the ventricular systole. Also, it may get detect a dilated left atrium and ventricle and decreased left ventricular function. We can also do cardiac catheterization in cases like underlying cases like coronary artery diseases. And coming to the differential diagnosis, tricuspid regurgitation, murmur increases with inspiration at left lower sternal border. In the aortic stenosis, murmur at the apex, and in the ventricular septal defect, pansystolic murmur is heard at the left lower sternal border. And the differential diagnosis are mitral stenosis and mitral valve prolapse. Sir.
Back from investigations. Starting from chest X-ray.
Yes, sir.
Okay. Cardiomegaly due to the left atrium and left ventricular enlargement.
Ventricular enlargement, sir.
How do you know whether the cardiomegaly is due to these ventricles or whether it is due to right ventricle or right atrium or it is complete dilated cardiomyopathy of all the ventricles? The striking point is straightening of the left heart border. It was the important word.
Left heart borders.
Cardiomegaly can be seen.
Okay, sir.
And coming to enlarged left atrium suggests double density. Okay, this double counter, one is from what are these two?
Left atrium and one is from right atrium.
Here, look. The one is of left atrium, the other is from right ventricle, not right atrium.
Right.
Right ventricle. The
Okay,
right heart border on its chest X-ray corresponds to the right ventricle. Okay. Why right ventricle is enlarged in this case?
Right heart failure, sir, due to increased pulmonary hypertension.
Loud P2. You already mentioned about loud P2. It says there is already volume overload
Okay,
is
sir.
on the right side. So this double counter you can explain. And Kerley B lines. Okay. Suggests pulmonary congestion. Okay. Kerley A, B, C, 3 lines will be there, and the most usually A will be on the apical side. A for apical, B
Apex.
basal. Okay, basal and perpendicular to the
Pleura.
Okay, go for the next.
Walking.
This you usually don't see. And what does this walking man mean?
Left atrial enlargement causes enlargement of the carinal angle, sir.
Okay. We usually don't see this. And what is Ortner syndrome? ORTNER. Whatever you mentioned, similarly, just near to the carina. What is the nerve? Okay, recurrent laryngeal nerve
Okay.
will be present. If it gets compressed because of the enlargement of the left atrium and whatever you said about this increase in the angle of carina will compress the recurrent laryngeal nerve, which causes hoarseness of voice in case of mitral regurgitation, which we call it as Ortner,
Hotness.
O-R-T-N-E-R, Ortner syndrome.
Okay.
Go. Next one, next one. ECG findings. Okay. Mm, okay, P mitral. The important thing to remember is don't just look up what P mitral, and when I gave you a ECG, can you find out whether P mitral is present or not? How do you pick whether it is present or not? There is a certain criteria.
Duration of the period is increased, sir.
Increase it up to what, and what is the normal value, and then you can say
More than 40 mil. More than 40 mil.
normally P wave will be less than
Yes, sir.
1 mm. Okay.
Less.
When do you call P
Yes,
mitral?
sir.
It should be more than 2.5 mm width.
Milli.
Mm.
Okay, sir.
You will call it P mitral, and you will take it as significant. And when 2.5 in case of lead 2. Okay. Whatever you mentioned later, you showed the image. I will again discuss.
Okay, sir.
You talked about left ventricular hypertrophy. Okay, tall R waves in the
Yes, sir.
leads. Okay, deep S waves. Why deep S waves in the right side precordial areas? Hmm? Left ventricle. Okay, left. The R waves on the left side corresponds to the left ventricle. Okay, and S waves on the
Okay, sir.
right side corresponds to the left ventricle. Okay,
Okay,
R
sir.
wave on left side and S
And
wave.
S wave on right.
S wave is the second negative deflection of QRS. Um, S wave on the right side will corresponds to the left ventricle. So deep S waves in the right side. Okay. Next. Go for ECG image. Go for image. Hmm. And lead to mention if this width is more than 2.5 mm, then you will take it as P mitral. Okay.
P
And
mitral.
in V1, there will be biphasic P wave, what we call it as
Negative deflection.
a positive deflection followed by negative deflection. Okay. And the negative deflection, if it is more than 1 into 1 mm, then you will take it as significant. Okay. If it is more than 1 into 1, then you will take it as P mitral.
Okay,
Go
sir.
for the next one. Echocardiogram. The definitive diagnosis for the mitral regurgitation is through echocardiogram. Okay.
Cardiologist.
I mentioned that confirmation. Go for the next one. Next one. Go for the next one. Differential diagnosis. Mitral stenosis can never be a differential diagnosis of. Okay. Never be a differential
Okay, sir.
diagnosis of mitral regurgitation. Mitral wall prolapse can be, and mitral stenosis can never be. It's completely different. There will be absolutely normal chest X-ray in case of mitral stenosis. Left ventricle will be normal size. Effects
Okay,
with
sir.
tapping are normal in case of mitral strain, absolutely contrasting to the mitral regurgitation. So it cannot be. And aortic stenosis. And what will be the murmur in case of aortic stenosis? Ejection systolic murmur. Okay.
Just
In case of tricuspid regurgitation is the first thing in the differential diagnosis, and how you differentiate, you have mentioned it, increases with inspiration. When it comes to mitral, it will be expiration at the left, the lower sternal border. Okay. In case of mitral, it will be
okay, sir.
at the apical area. Right. Next, aortic stenosis marker at the apex. Maybe you mentioned it wrong.
Yeah.
Marker at the aortic area or second right intercostal space. You should mention. Okay, the maximum intensity will be at the aortic area, and you should know
Okay,
about.
sir.
mm, ever come across Gallawardin phenomenon? Mm, okay, let me
Rejection, regurgitant flow. So,
tell you about that. And what is this?
during inspiration, it will occur.
Gallawardin, you were saying. In case of aortic regurgitation, in case of aortic stenosis, there will be a filtered some filtered frequencies will reach the apex and they resemble like mitral regurgitation, which we call it as Gallawardin phenomenon. Next, VSD. Okay,
Okay, sir.
VSD is right. Okay, go for next. And the first differential diagnosis you should mention about after investigations. Okay, in provisional diagnosis, the differential diagnosis should be the first one should be ischemic heart disease. Okay.
Okay, sir.
And how do you differentiate ischemic from the mitral regurgitation or rheumatic heart disease? Hmm? Valvular lesions. Valvular. For that, you are doing echo, right? Echo,
Yes, sir.
you will look for the vegetations on the wall or thickening of the wall or stenosed valves. They helps to differentiate the ischemic heart. In case of ischemic heart disease, there is a global hypokinesia. In case of ischemic heart disease,
Okay, sir.
other condition, the pumping will be normal. Next one. Fourth question.
This is the last.
Hello.
Good morning, sir. Can I share the screen, sir?
Share.
Good morning, sir. Now I am about to present management of regurgitation. Under medical management, the patients with mitral regurgitation are treated with diuretics, anticoagulants, beta blocker, AC inhibitor, angiotensin receptor blocker, digitalis, and cardiac resynchronization therapy. Under medical management, patients of mitral regurgitation are treated with mitral valve repair and a mitral valve replacement. Medical treatment. Patients with acute mitral regurgitation require urgent stabilization with diuretics intravenous vasodilators, particularly like sodium nitroprusside, medical support for patients with post-MI papillary muscle rupture. Management of a chronic mitral regurgitation depends on etiology to some extent. Chronic severe mitral regurgitation can be treated medically with diuretics. If systemic hypertension is present, it is treated with vasodilator like ACE inhibitors and angiotensin receptor blocker, because the high afterload will worsen the mitral regurgitation. Anticoagulants and cardioversion is given if atrial fibrillation complicates the mitral regurgitation. Beta blocker, ACE inhibitor, digitalis, cardiac resynchronization therapy, and along with the diuretics are given in a chronic secondary mitral regurgitation like ischemic or dilated cardiomyopathy. Antibiotics are also given to mitral regurgitation patients with the prior history of infective endocarditis. Direct oral anticoagulant should not be used in rheumatic mitral stenosis and a mechanical prosthetic valve. And patients with mitral regurgitation with the normal left ventricular size and normal systolic function should avoid isometric exercises. Surgical treatment for acute mitral regurgitation. Patients with acute mitral regurgitation can be stabilized temporarily with medical therapy, but the surgical treatment is necessary emergently in cases like papillary. Surgical treatment for chronic mitral regurgitation. Indications for mitral valve repair. Patients with symptomatic mitral regurgitation, surgery is indicated once symptoms occur, especially if the valve is repaired. Surgery should also be indicated in asymptomatic patients with left ventricular dysfunction with less than 3% of ejection fraction and the left ventricular end diastolic dimension with more than 40 millimeters and the recent onset of atrial fibrillation within less than 3 months, and pulmonary hypertension with a pulmonary artery systolic pressure with greater than 50 mm of mercury in resting and greater than 60 mm of Hg while exercise, and progressive decrease in the left ventricular ejection fraction or increase in the left ventricular end systolic dimension. Surgical treatment of chronic primary mitral regurgitation. The surgical repair of mitral valve consists of various techniques like chordal transfer, recreation of neocords, limited leaflet resection, insertion of annuloplasty band. Mitral valve repair is preferred over the mitral valve replacement because the repair spares the patient the long-term adverse consequences of the valve replacement like thromboembolic or hemorrhagic complications in case of mechanical prosthetics and late valve failure necessitating the repeat valve replacement in case of bioprosthetics. In addition, by preserving the integrity of the papillary muscles and the subvalvular apparatus, and mitral repair and the valvuloplasty maintain the left ventricular function more than the valve replacement. Long-term durability is very good in the mitral valve repair, and incidence of a reoperative surgery for failed primary repair is only 1% per year for the first 10 years of the surgery. For patients with atrial fibrillation, left or biatrial maze surgery or radiofrequency isolation of the pulmonary veins is often performed to reduce the risk of the recurrence of atrial fibrillation post-operatively. Surgical treatment for the chronic secondary mitral regurgitation. The surgical repair is done by the annuloplasty repair with undersized and rigid ring or cord sparing valve replacement. Patients with ischemic mitral regurgitation most often undergoes the simultaneously coronary artery revascularization. The routine performance of valve repair in patients with a significant secondary mitral regurgitation due to dilated cardiomyopathy do not show any improvement in long-term survival compared with optimal medical therapy. When the surgical treatment is necessitated or contemplated, the left and the right heart catheterization and the left ventriculography may be helpful in the presence of severe mitral regurgitation in patients with whom the clinical and transthoracic echocardiogram findings are cannot be resolved with the transesophageal echocardiogram or cardiac MRI. Mitral valve repair and replacement. It is visible on selected patients with appropriate anatomy. The like deployment of a clip delivered by transeptal puncture that grabs the leading edges of the leaflet at the A2 and P2 and the anterior scallop. The length and the gap between leading the and another techniques like edge-to-edge technique to reduce the left ventricular ejection fraction and secondary mitral regurgitation. Deployment of a device in coronary sinus that adjusts the mitral annular circumference and effective orifice area of the valve. The septal lateral dimension of a dilated annulus using adjustable cords placed in the left ventricle in subvalvular location, and the construction of a new cord under transesophageal echocardiogram guidance.
Go for the slides. Go for the slides. When do you expect acute MR?
Papillary muscle rupture.
When does it occur?
And infective endocarditis or papillary muscle rupture or blunt trauma
or myocardial infarction.
Caudal rupture.
Okay. Myocardial infarction. Next, chronic.
Papillary muscle rupture.
Most common cause of chronic in Western countries.
Infective endocarditis.
Mitral valve prolapse. Okay. Next, will the medical therapy will improve the survival of a severe MR case of primary etiology? If it is primary MR, will the medical therapy improve the survival?
Yes,
Did you get my question? Hello?
no, surgery is required for primary. Surgery is required for primary.
Medical therapy, but the definitive is surgery. Okay. And we don't prefer still now oral anticoagulants has
Mitral valve.
Okay, not approved for
Dramatic mitral stenosis.
doesn't mean the contraindicated. It was not approved for the therapy.
Okay, sir.
Okay. Next slide. The definitive treatment for an acute MR is surgery.
Surgery.
Okay, surgical indications for chronic MR. If it is severe, definitely we will go for surgery even if it is asymptomatic. When do you go for a when do you, if it is asymptomatic, what are the parameters that will make you to do surgery or is okay. And we call it mild mitral regurgitation. When do you call it mild? It is the regurgitant is less than 30%. 30% of the total. Or less than 30 ml. The regurgitant just is less than 30. Anything more than is moderate, and anything more than 70%, 60% will go for severe. Okay, go for the next one. This is the procedure of the repair. Okay. Have you ever come across Mitra clip? Mitra clip, MITRACLIP. The voice is not audible.
Transcatheter repair.
Mitra clip.
Used in transcatheter.
So former President Kalam and Sri Chitra College together. Okay. Mitra clip. Okay, secondary MR. Secondary MR, the reason for regurgitation is what part of the
Ischemic or dilated cardiomyopathy, or
what part of the valve apparatus is responsible for secondary MR?
annular ring.
Only the annular dilation. MR causes atrial fibrillation, and chronic atrial fibrillation will also cause MR. Okay, chronic atrial fibrillation will cause dilation of the left atrium because of the inappropriate contraction. This dilation of left atrium will cause dilation of the annulus. It causes secondary MR. MR causes AF and AF causes MR. Both can cause. And there is a famous saying like MR begets MR. Okay, it's a vicious cycle. MR will further worsen the MR. Okay, next. Okay, next slide. This is what we are talking about. In Mitra clip, we will clamp the A2 and P2. So in the beginning, it will
P2.
1/4 the regurgitation. It doesn't totally stop, but it will decrease the regurgitant flow. Next one. Okay, these are the last steps in the procedure. Go for the next one.
Complete it, sir.
Fine. Okay, thank you. Do you have any doubts? Anyone in the class can ask.